Hello, I'm Jeff Ponsky, and as one of my sons, Todd, would say, good morning, good afternoon, good evening, wherever you are. We are broadcasting now from the Cleveland Clinic in Cleveland, Ohio, and this is a new type of program that I want to describe to you a little bit. This program is designed to present information on various topics. It's a series of programs for physician engagement. What we're going to do is we're going to present throughout the year a series of 6 programs each year, which are on various different topics, to engage both our faculty at various different sites throughout the world, and also the doctors who work with us and refer to us, who are part of our team in providing the best care we can. We believe that this is our effort to give back and to provide value to our doctors who are partners in the care of these patients. So we want to tell you a little bit about the ground rules here. This is meant to be fun. This isn't a formal lecture. We want you folks to participate. We want you to get involved. We want you to laugh with us, be confused with us, ask questions of us, challenge us, debate with us, and have fun doing this. If we don't do this, then we're just lecturing to you, and that's no fun at all. So we're going to have this program, and this program is free of charge to everybody who wants it throughout the world. Today, for example, I think we have about 150 centers and about 25 countries participating. That's free. We've been told that in order to provide continuing medical education and self-assessment, the legalities are that we have to charge $30 an hour, and this is a 6-hour program. That's entirely optional for you, and it's a worthwhile way to get CME and self-assessment. We are going to archive this program. It will be online at the Cleveland Clinic website for 2 years, and anyone wishing to go and get CME or review the program can do that. This will be the same for all the programs that we run. This is our physician engagement series, so if you see those terms, you know what we're talking about. Again, this is supposed to be fun. This is a chance for us to talk to each other. We're going to involve not only our local faculty at Cleveland Clinic, Cleveland, but our faculty throughout the world. And today is a perfect example of that. And let me introduce our faculty for this morning, because we're going to have 4 sessions today. First, Scott Gabbard, who's on the faculty of the Department of Gastroenterology here in Cleveland, Ohio. Scott is an expert in esophageal diseases. We also have Dr. Ronnie Pimentel, and Ronnie is coming to us from Fort Lauderdale, actually Weston, Florida, where I have the privilege of going once in a while, and Ronnie is just a superb gastroenterologist and a good friend. And finally, Kevin Hayek, Kevin L. Hayek, who is in Abu Dhabi. And Kevin was here for a bit, and he trained here, and now he's in Abu Dhabi, and he's going to lead the surgical effort in general surgery and foregut surgery there. And I can tell you he is a superb foregut and esophageal surgeon, and he's going to participate today. So I want to thank you all for coming. We're going to have different faculty throughout the day as we go on to different parts of this discussion. The first part today, the first session of all this series is on esophageal disease. Now, many of us think that the esophagus is just a hollow tube and that the food goes from the top to the bottom and just drops down. And it's really not like that, is it? The esophagus is much more complicated, and we keep learning about it more and more. I keep learning about it. The esophagus, it has a motility issue to it, it has a potential for neoplasia, and it suffers disease, inflammatory disease, and we're going to try to talk about those today. We're going to start simply, and we're going to talk about reflux disease, gastroesophageal reflux disease, or GERD. Now, before we get into these complicated cases, I'm a simple guy. I want to tell you about the best case I can do. This is when one of my young partners comes to me, and he says, Jeff, he's a 40-year-old guy, and he says, I've had heartburn for a long time. I've been a resident in surgery for a long time. I've had heartburn, and I just take Rolaids for relief. I've never seen a doctor. I don't want to see a doctor, but I've been otherwise well. What do I do? So what would you do for a guy who came to you like this? Ronnie, I want to ask you that. What would you do if one of your young partners just came in and said, you know, I have a little heartburn and it bugs me. I take Rolaids. What would you tell them?
Well, first of all, you try to see if there's anything in the history that brings or raises a red flag in terms of complicated disease, such as dysphagia, suggesting strictures, or even malignancy. And also you try to get a feeling if this guy is worthwhile, just a trial of PPI, lifestyle and diet modification, and then if he fails, doing an EGD, or should you do an EGD to begin with based on his age, his race, BMI, central obesity, looking for Barrett's.
All right, wait, whoa. I want to stop you a minute there, because here's this guy looking at you. He's right, he saw you in the hall, you know, and he says, Ronnie, come on, you know, I'm just having a little heartburn. I've had this heartburn for a long time. What can you tell me? So, you know, wouldn't you just tell the guy to go on PPIs? What do you think, Scott? Would you put him on PPIs right away?
Well,
I mean, Ronnie asked the important questions. Ronnie said, you know, he asked the questions to rule out other diseases. Do you have dysphagia, any family history or anything? But some of the guys otherwise negative. What would you do with them?
It depends on how bothered he is by the symptoms. You know, how often is he having symptoms? Is this every time he goes out to the steakhouse and eats a big steak and a bottle of wine, or is this every night? And so you really have to pressure him. How much are you bothered by your symptoms?
It bothers me enough to talk to you about it. Okay, I'm embarrassed to talk to you about it. I'm a doctor. I'm not supposed to have symptoms. But he's embarrassed to talk to you about it. But it bothers him every day.
There you go.
Every single day.
So I think that that's absolutely worthwhile to start a PPI.
All right.
In that situation, if he's bothered every day, I think, you know, that's a time to start a daily medicine. PPIs are very safe, cheap, they're very effective.
So let me keep talking about this. So you see him back. You start him on what, 20 of Prilosec a day or something like that, omeprazole, and the guy sees you in the hall 2 weeks later, and he says, I feel great. I mean, this really made a difference. Ronnie, what would you do now? The guy feels terrific. He doesn't want to talk to you anymore. What would you do?
Well, that's okay. I think it's reasonable to continue the PPI for 8 weeks or even 3 months and then stop and see if his symptoms recur significantly. And personally, I think that somebody I'm going to condemn to take PPI for the rest of his life, I would do a one-time endoscopy. If they do well and the symptoms after modifications are very sporadic, then I said, you know, that's fine. If every so often you need a PPI, but you don't need it on a regular basis, that's okay with me.
All right, so I want you to tell everybody why you would do the one-time endoscopy. That's really what I wanted you to get to. Why do you want the one-time endoscopy?
I mean, if this is a male, white male, obese, I think if he's going to have Barrett's, he's going to have Barrett's now. And you'll be able to spot this guy and then put him in surveillance. And we can discuss about surveillance some other time. But if he doesn't have it, I think he's not going to develop after that. And you can follow him clinically from there on.
All right, so I want to stop you right there. You raise a great point. I think you need that screening endoscopy if you're going to keep him on PPIs. And you're looking for Barrett's. There was a gastroenterologist who was a great friend of mine. He's still around in Tampa, Worth Boyce. And Worth Boyce was an expert in esophageal disease, and I've heard him say, if you scope an adult once and he doesn't have Barrett's when you first scope him, he won't get Barrett's for the rest of his life. Do you guys still agree with that? What do you think, Scott? Is that true?
I think that's pretty true.
All right, so that screening endoscopy is a good test. For, I mean, one time, and then somebody you're going to treat for a long time with PPIs, right?
Well, why not wait until his screening colonoscopy at age 50?
So you would be comfortable waiting 10 years and treat him with PPIs for 10 years before you did a screening endoscopy?
Well, I don't think that that's an unreasonable choice. If you know, going by the guidelines, it's fairly rare to develop esophageal adenocarcinoma before the age of 50. Can happen, but it's pretty rare. So again, you look at the patient's risk factors, what Dr. Pimentel had mentioned earlier. You know, is he obese? Does he have a family history? How long has he had the GERD symptoms for?
Okay, now, so I want to get into this a little bit. So Ronnie, would you feel comfortable waiting 10 years, or would you scope him after 8 weeks and he still wants to take his PPIs?
Not in Florida. I won't look.
You would look.
I wouldn't wait. I wouldn't give this guy a free pass of PPI for 10 years and then look. He may not come back ever.
I really believe that in the future there's going to be screening for Barrett's that may be even simpler than endoscopy, and there's a lot of people working on this right now. The capsule, for example, was one way that people could look without an endoscopy, and I think there'll be more in the future. So as we go along, people are constantly working on ways to screen for Barrett's even without endoscopy. But I feel comfortable in my practice, and I see friends of my kids and friends of mine who have this exact same story, and what I tell them, if you're going to take PPIs, you owe me one endoscopy. I'm happy to write the prescription over and over again, but you owe me one endoscopy. So I think that's what I would do. Kevin, anything different from you on this? What do you do?
I agree. I would favor one endoscopy. I really would. I think 40 years old, you end up really getting a fair amount of information, and you know, I'm in agreement with the panel.
Okay. So let's now go ahead to some cases, some other cases that are a little bit more difficult, because I gave you the easiest case. We wish we all had that easy case. So let me go ahead to Kevin. You want to present your first case? You have it there?
I do. I'm going to share my screen with you.
Okay. You're very good at this, Kevin. That's good.
All right. Can you see that?
I love the hospital. It is gorgeous. Have to come visit you someday there.
We'll get you here. So before I get started, I definitely want to thank the Globalcast crew for inviting me, for the panelists, and certainly I need to thank Dr. Ponsky, who has been a mentor of mine for many years, and I was delighted to hear he was coming to Cleveland Clinic, and I was happy to share my office with him last year. And though I wanted someone who was tall enough to reach some of the higher level books, I think you guys can judge from the line that it was appropriate to have someone of equal stature. Thank you for allowing me to share some space with you during that time. So I have no disclosures. You guys hear me?
Yes, very well. Go ahead.
Okay. So this patient, I was asked to do some complex cases. This first patient is a 35-year-old gentleman. He has an 8-year history. Dominant symptoms included regurgitation, heartburn, and nocturnal symptoms with secondary bloating and diarrhea. So his prior evaluation and treatment, he's an athletic build, football coach with a BMI of 32.5. A lot of this BMI, I would say, is in his upper body. He was a very muscular gentleman. However, he also had some intra-abdominal GERD. So he did have an EGD. It showed no hiatal hernia, small linear ulcer, a small hiatal hernia again on the upper GI that was seen. And he was placed on a proton pump inhibitor, 40 milligrams daily with antacids as needed. So at this point, I'll open up the first question and ask the group and the panel, as well as our folks in the audience, what would you do next?
So at this point, we could say that we could, Jen, we could do a poll of the audience just to practice our polling skills. So if everyone wants to tell us what they would do, A, increase your PPI frequency and add an H2 blocker. And how would you add that? We'll talk about that later. Esophageal manometry, pH probe off of medication, or a repeat EGD. And that'll take a little while to come up. So while we look at that for a second, let's see what would you suggest, Kevin?
So I would recommend increasing his proton pump inhibitor and adding an H2 blocker given his nocturnal symptoms.
So you would add that at bedtime? At bedtime?
Correct.
Okay.
At bedtime.
That's an interesting approach. Let me just ask Scott about that for a second. How about adding an H2 blocker to a PPI? Is that becoming more fashionable?
It was fashionable a few years back. I think there was one small study that showed that it would help with symptoms. In clinical practice, I find that it's less helpful. Now, the one thing you want to make sure of is if a patient's taking an H2 blocker at the same time as their PPI, it may actually decrease the efficacy of the PPI. So if you do have a patient who's taking an H2 blocker and a PPI, make sure that they are split. You need some acid in the environment in order for the PPI to be effective. You also have to make sure that the patient's taking the PPI correctly. And the best time to take most PPIs is 30 to 60 minutes before meals. That's one thing where a few studies have shown that the majority of patients on PPIs are not taking them correctly during the day. So it's really important to make sure that he's taking the PPI correctly.
Okay. Go ahead, Kev.
Okay, so this was increased. He also had an H2 blocker added at night. And we also, at this point, recommended a GI consultation at Cleveland Clinic. He did have added this, as I mentioned. He also underwent a full workup at that point. He had esophageal manometry, repeat upper endoscopy with biopsies, and a Bravo probe was placed, or wireless pH monitoring. So unfortunately, and this is a patient I followed for several months, he had persistent symptoms, regurgitation more so than heartburn, and the repeat endoscopy, which I'll show, did show a little bit enlargement of his hiatal hernia up to 4 centimeters. He did have biopsies at that point, which were negative for celiac disease, and this was done because the patient had some bloating and diarrhea. His manometry showed a mildly hypertensive lower esophageal sphincter, and a pH study showed a no acid reflux on medication. So at this point, here we can show the upper endoscopy did show this small sliding hiatal hernia, which is appreciated here, again on retroflex view. There were no linear ulcerations at this point. So at this point, again, I can offer this up as a poll. And the result of the other poll was that 57% of the audience increased proton pump inhibitors and added the H2 blocker.
Okay,
yeah,
I see that you're talking about some of these devices now, and it might be worth spending a moment to talk about some of these devices and what they are, because they're really not widely used right now. Do you want to mention them real quickly, Kev?
Yeah, so the first letter A is endoscopic fundoplication. This is a technology that has come and somewhat gone, which involves essentially a retroflexion and a suturing of the fundus endoscopically. The next one is flexible magnetic bead LES augmentation, which is essentially a ring around the lower esophageal junction. And this is magnetic. So what happens is as the food bolus reaches the lower esophageal sphincter, the beads open, the food goes through, and then it closes behind the food. And this is FDA approved for reflux disease. However, in the setting of a hiatal hernia, this would be contraindicated. So for minimally invasive Nissen fundoplication, this would be the gold standard for reflux disease in the setting of a type 1 hiatal hernia with persistent symptoms. And medical or surgical weight loss therapy, I think it's probably important to discuss in a patient with a body mass index approaching 35, and in this gentleman, 32, 33, body mass index is a pretty high one. So I'd like to hear maybe from some of the panelists as well about the body mass index. I think there's a fair amount of literature about doing Nissen fundoplication in high BMI setting.
So if I could interject a little bit here, I think that it's important to say a couple of things about the endoscopic therapy for GERD. And can I have my screen back for a second? If I can have my screen back, I'd just like to talk about that for a quick second. Can we have my screen back, Mark? Okay.
Oh, I'll stop sharing this.
Okay, so let me just go to my screen for a second and show there are a few things. This is Esophax, which Kevin mentioned. It's probably the only device on the market right now which is probably effective, really effective, for strengthening the lower esophageal sphincter, and it has documented results in reducing the acid exposure in the lower esophagus. However, its durability is really questioned, and this is what it looks like after you do it. And it looks a lot like a Nissen fundoplication looks, but its durability is still in question. It depends upon plastic T-fasteners to go through both layers there. But it is an interesting device, and it's the one that is the most effective, but a bit invasive. This is what Kevin mentioned as the magnetic ring. Actually, this is just starting to be used. This is put in surgically. This is not endoscopic. This is you go in like a Nissen fundoplication, but instead of doing the fundoplication, you put this magnetic bracelet around the EG junction, and it stretches each time the food bolus goes down. It's called the Lynx, and we're still evaluating it. And whether or not it'll be better than a Nissen fundoplication is problematic. I just wanted people to know about it. The other thing that is available is Stretta. And Stretta is an endoscopic therapy, which I say is a little bit like kissing your sister, because it's not very satisfying, but it gets the job done. And it's sort of like the Stretta is, it's a radio frequency energy applied to the muscular wall of the esophagus with needles after a balloon is blown up. There cannot be a significant hiatal hernia there in order to do it. It takes about 45 minutes to do the whole procedure endoscopically. And we used to think that it worked by thickening the muscle and collagen, but actually now believe it destroys vagal afferent fibers, which causes the transient esophageal relaxation, so that it prevents the relaxation. In sham trials, it seems to have some effect, but it does not reduce the acid exposure to normal levels. It just reduces them a little. So it is effective, and it might be tried. It has very little downside to trying it. So those are the things that Kevin was alluding to. I wanted to just show the people, the participants, what he was talking about with this. So Kevin, if you can give us back your screen, and we'll let you go on with that case. This is the Nissen that you're going to show us?
Yeah, so just to give the results of the poll, about 25% recommended endoscopic fundoplication, and 50% recommended a minimally invasive Nissen fundoplication. What I'd like to show with this video is a newer technology, obviously a robotic Nissen fundoplication. This is not slow motion. If Dr. Rodriguez was there, I would allude to him. This is me teaching Dr. Rodriguez a little bit of robotic surgery. Pretty controversial to perform a Nissen fundoplication using robotics. This is a standard operation being done laparoscopically. However, I think most would agree that the image quality is very, very strong. That's one of the benefits of performing this minimally invasively. There's also a stable camera platform that allows for fairly precise dissection, especially up in the hiatus. So what we're performing here is dissection of the greater curvature up to the level of the left crus. And as we move along, what I'd like to show is the shoe shine maneuver being done with the fundus out. And once we perform that retroesophageal window, this can be managed with the same way we do this laparoscopically. We make sure that we get intra-abdominal esophagus of at least 4 centimeters. The closure of the hiatus is again done using suture, in this case silk suture. And again, I think, Dr. Ponsky, maybe you can say a few things about performing this laparoscopically and just sort of, the discussion about the use of the robot in the hiatus.
Yeah, don't get me started on the robot. I think that the robot is going to have great potential in the future as it becomes more and more able to help us do difficult techniques. I think we have to learn to use the robot on some simpler techniques, and I think this is an example of that. This operation can be performed very nicely without the robot in exactly the same way, but again, you're demonstrating how we use the robot. The dissection is excellent. Let me ask you a question as you show this wonderful procedure. What if this guy's BMI was 40? Or would you still do this operation in this fellow? And why or why not?
So that's an excellent question. We've looked at our results long term on Nissen fundoplication specifically in the cutoff of using the cutoff of 35. One of the reasons we use 35 is that's when you can begin to apply bariatric principles to these patients and can actually achieve insurance coverage. Once the BMI hits 35, the Nissen fundoplication success rate starts plummeting into the range of about 50 to 70% failure rate. So the higher the body mass index, once you hit that body mass index 35, the more chance that your Nissen is going to fail long term. So if his BMI was 40, I would not perform a Nissen fundoplication. I, in fact, believe that if you do that, you're putting the patient at more than a coin flip's chance of having a recurrence at that point.
And I think that's a great point to make, because when you see these heavy patients and they come in and they need a Nissen and you're so tempted to do it, I can tell you that in my career I've seen a lot of them fail, because some of them get heavier after they have the operation because they enjoy eating so much after that. But so tell us, Kevin, what's the operation for someone with a BMI of 40 and reflux?
So even for this gentleman, I counseled him heavily. I said, you know, your body mass index, even though you're an athletic gentleman, you're in your 30s, but the likelihood of kind of staying at this level into your 40s is low unless you know that you'll have a tendency to go up with this operation in terms of your body mass index. The gold standard for a BMI in the 40s for reflux disease at this point in many communities would be considered a gastric bypass. So Roux-en-Y gastric bypass, what we considered as a parietal cell separating procedure with a Roux-en-Y reconstruction. Many people would argue that it's quite drastic. However, the durability of that operation in the setting of reflux with the associated comorbidities with a BMI of 40 is the most durable operation. And we'll talk a little bit more about that when we move into the motility section.
Ronnie, did you want to say something?
Yeah, well, we moved from the symptoms to the endoscopic or surgical intervention, but are you really convinced that this guy's symptoms are due to that hiatal hernia? I mean, from a non-surgical perspective, we see a lot of problems in people having Nissens and stuff like that. I mean, there's some red flags on this patient. He has a very minimal esophagitis on endoscopy. He has a proven pH that is responding to relatively low doses of PPI. And he has other functional symptoms. You mentioned about bloatiness, diarrhea. They already look at him for celiac. And I think the success of all this intervention depends on patient selection. And sometimes you do these operations in people in which the problem is a functional component, and you never get it off your practice because the symptoms never go away, and these other people are going to have gas bloat symptom and chest pain and this and that.
So I think that's a great point, Ronnie. And patient selection is everything. And we live with our complications forever and ever. So the question is, after and I have another case that's very similar to this, and let me present it real quickly now, if I can, because these patients are very difficult. And here's a case. Let me just show this case, and Ronnie can comment on this. I have a 63-year-old dentist who I just saw this fellow. He has 4 months of severe substernal burning. He has pain with eating every time he swallows. His cardiac workup's negative. His EGD, like this guy, was sort of negative. He has some relief with PPIs, but he lost 15 pounds. All workup was negative. His CT was negative. pH, his Demeester score is only 11. And so what would you want to do with a guy like this?
I have a very low threshold to do 24-hour pH with impedance in these people to see if this really acid or this is hypersensitivity, or maybe, yes, he doesn't have acid, but because of the hernia, there's a lot of stuff coming up, and fixing the hernia, you may improve this guy. And I want to see his symptom correlation of all this belching and all this stuff really has to do with fluid coming back what is all in his head. Because once you intervene on these people, all bets are off.
Yes, I think that's such a good point. So if I could show my next slide, I put down the role of manometry, because we want to look at how manometry can help us in a detailed, and I'm going to have Scott talk about manometry a little bit more. Ronnie mentioned impedance, because that can tell us about regurgitation and fluid coming back up without the necessary being acid. How would we evaluate for bile reflux? And Ronnie, do you evaluate patients for bile reflux?
Well, I try to approach people a bit more from the internal medicine point of view. I really take a good history in these people in terms of functional things. It doesn't hurt to give them a trial of carfate to see if that helps, but most of the time I find that people who really is going to benefit from a operation, either endoscopically or surgically, either these people have breakthrough of acid with in the pH, or they have grossly grade 2 or grade 3 esophagitis. Once you start getting all this doubtful results, you need to be careful about things. That's my take on this thing. So maybe I see the patients up to the fact and I don't see the success stories.
So I have to tell you that as someone who's been operating for 20-some years on reflux, I'm very careful about reflux now. On Nissen fundoplication, I want to emphasize your point, Ronnie. I think they really need to be carefully selected to get good results, because once you operate on them, then you suffer a whole set of different problems. And I think Kevin has a case later that shows some problems, but you can get slip Nissens, you can get the Nissen too tight or too loose, and then you have a whole different thing to sort out. So I agree with what you said wholeheartedly, and it's much easier for me to decide to fix a paraesophageal hernia, which is a different story, than it is to fix a Nissen for reflux, because you really have to sort it out. What about the role of antidepressants in patients who have atypical reflux? What do you think about, Scott? What do you think about that?
Well, I think that gets back to why is this patient failing? And you mentioned that he had a pH probe test, and I have a case that sort of goes through this. We didn't know if that pH probe test was on or off of PPIs. You get a couple of good variables, good results when you do a pH probe. One, you get the percent, the number of reflux events, and the percentage of time when the pH is less than 4 in the distal esophagus. Those are very helpful. The other results that you get that may not be paid attention to is what we call the symptom index, or the symptom association probability. So there's a button on the pH probe, and patients are instructed to hit the button when they feel, be it chest pain or regurgitation or belching. What we then do is we correlate, when they hit the button, is there acid in the esophagus? So, for example, I saw a patient who hit the button 130 times on a pH probe when she was off of medicine. Of those 130 times, 4 of them were when there was reflux actually in the esophagus. So the other 100 whatever, there was no acid in the esophagus. That's a condition we call functional heartburn. There's no correlation between acid and her symptoms. That's a nerve disorder of the esophagus. She will not benefit from PPIs, and she won't benefit from surgery. That patient needs some sort of medicine that's going to modulate the pain sensory nerves in her esophagus. And that's what I tell them. And that's where antidepressants, there's some data for SSRIs and some data for low doses of tricyclic antidepressants for use in those patients. Now, there are some patients who have normal levels of acid exposure in the esophagus, but when they hit the button every single time. That's when acid is coming up. Those patients have overly sensitive nerves. It's similar to what I just mentioned, the functional heartburn, but that's what we call hypersensitive esophagus. Their nerves are overly sensitive. And these patients, these functional heartburn and hypersensitive esophagus, these patients often have overlap with functional dyspepsia, irritable bowel syndrome, all of these visceral hypersensitivity nerve disorders of the gut. And again, I don't like sending them for a surgery because they're often higher risk to develop dysphagia or worsening of their functional dyspepsia after surgery. Again, those are the patients that I'll try to get on pain modulator therapies, be it an SSRI or a tricyclic antidepressant.
I think that's an important point. I think we have to try everything medically to manage these patients with reflux symptoms before we operate on them, because once we operate on them, if they have recurrent symptoms, it becomes very confusing. All right, let's go on to Scott and your case. Can we do that? Let's see if we can go on here.
And these cases have a lot of overlap.
They should. Go ahead.
So that's okay. It's not a bad thing. I've got a very similar patient to Kevin's. Here's a patient, he's got postprandial heartburn and regurgitation, occurs on a daily basis, and he's taking his PPI twice a day correctly, so 30 minutes before meals. Now, interestingly, he says, "Doc, my heartburn is gone, but I still have bad regurgitation." And, he says, I don't want to take PPIs for the rest of my life. Now, unlike Kevin's fairly athletic patient with a BMI of 32, this patient has a BMI of 25 and is fairly athletic. No other medical problems. This picture didn't show up very well, but he got an EGD, and you'll have to take my word for it because it doesn't show up very well. But this is all ulcer here, and here and in many places they use the Los Angeles grading system for erosive esophagitis. I figured I'd just take a little break and remind everyone what that is. So there's grade A to D erosive esophagitis. Grade A being an erosion that's less than 5 millimeters. Grade B being an erosion that's greater than 5 millimeters. Grade C is an erosion that spans 2 gastric folds, but overall of the circumference of the esophagus, less than 75% of the circumference is ulcerated. And then grade D is greater than 75% of the esophagus is ulcerated. And this patient here had an EGD. Take my word for it, this is all ulcer. This was before he started his PPI, and he has a small 2-centimeter hiatal hernia.
And do you biopsy that?
In patients with grade C and grade D esophagitis, what I will do is give them PPI therapy and repeat their scope 3 months later to ensure that it heals.
Yeah.
And for grade A and B esophagitis, the recommendations, you don't have to repeat a scope to make sure that they heal. But grade C and D, you want to make sure that when they do heal, if they have a large amount of erosive disease, you want to make sure there isn't any Barrett's or anything else hiding under there.
Yes, okay.
But most of the time, if it's inflamed, you take biopsy, the pathologist just comes back with acute esophagitis. Doesn't really help you clinically because you already know this is reflux disease.
So this is the weather map from today's
This is it.
news.
So all this green is opening day, all the rain that we're going to get here in Cleveland
It looks like it.
for opening day. So what this is manometry. This is a high-resolution manometry. So this is a catheter that goes through the nose down into the stomach. It has 36 pressure sensors on it, and then it ends up, you get this nice topography plot.
So that's actually a picture of the esophagus.
This is the esophagus. This is the pressure amplitude of the esophagus. I don't know if you can see my mouse right here, but I want to go through the parts of the esophagus. So up here, this is the upper esophageal sphincter. Going back, maybe I'll talk about the colors. So blue and black is no pressure. Then you go up to green and yellow, which corresponds to a pressure in the 30s and 40s for green, and yellow it's in maybe the 50s and 60s. You go up to red, that's a pressure around 100, and then you get to these purples, which is a higher pressure, and these colors change depending on how you have your equipment set. But you can see here, this band right here is the upper esophageal sphincter. The top is the proximal esophagus. You have to remember this is striated muscle. And then the bottom is the distal esophagus, and here you have smooth muscle. And then this line down here is the lower esophageal sphincter. Now what's interesting here about this one is you see before the swallow there isn't much pressure here on the manometry. Now I always take pressure readings of the LES in manometry with a grain of salt, the test that I want to figure out if the lower esophageal sphincter is working, to me that's a pH test off of medicines. The LES is supposed to prevent acid from coming up. So if I want to know if the LES is working in terms of reflux, I will do a pH test off meds. If you're trying to figure out if the lower esophageal sphincter isn't opening, then obviously in a case like achalasia, that's where we do manometry. So here in this reading, the patient swallows here. So the upper esophageal sphincter turns blue. There's no pressure. It opens up. And you have this nice pressure wave in the proximal esophagus going then into the distal esophagus. And then you see here the lower esophageal sphincter relaxes to allow that bolus to pass in. And then after the swallow, you see some pressurization of the lower esophageal sphincter. So this is a nice normal esophageal manometry. So the patient here, low LES pressure is otherwise normal peristalsis. So I wanted to bring up the point, and maybe I'll ask my surgical colleagues. So would you consider a patient who has grade C esophagitis an appropriate candidate for anti-reflux surgery? And I guess I wanted to ask Dr. Pimentel, Dr. L. Hayek, Dr. Ponsky, what does a patient have to prove to you that they have reflux in order for you to do a fundoplication or an anti-reflux surgery?
Kevin?
So that's a great question. I feel like I should answer Ronnie's comment as well. One of the benefits of being in an institute model is that many of these patients are followed both by myself and one of our esophageal specialists. So I would rarely operate on a patient who doesn't get a recommendation from a gastroenterologist that they basically have run out of options medically. And I agree that I would want some objective evidence that this patient would do well with either regurgitation symptoms with non-acid reflux or with documented reflux with some contraindication to take proton pump inhibitors. The atypical cases are always challenging, and for that reason, those patients almost invariably are seen in a swallowing, multidisciplinary way before we operate on them, if we do.
There was a nice paper that came out last year that was a symposium of gastroenterologists, surgeons, that made some nice recommendations, and their recommendations, and obviously these are open to interpretation, but the recommendations were a patient should have documented evidence of reflux disease, and what they said was documented evidence was either grade C, grade D esophagitis, or a positive pH test off of PPI. So you have to have one of those two, but you have to have some sort of objective evidence that you have abnormal acid in the esophagus. And so that I follow that in my own clinical practice. If a patient has grade C, grade D esophagitis, I think it's reasonable to consider fundoplication if they're the right patient. If not, if it's grade A, grade B esophagitis, or if they have normal looking esophagus, I will do a pH off meds.
So if a patient comes to me and has Barrett's esophagus or stricture, or grade C esophagitis, I don't even get a pH test.
Absolutely. And I didn't mention Barrett's esophagus. Yeah. If they have a segment longer than 3 centimeters, I consider they have absolutely reflux disease. Right. If they have a short segment, if they've got one of these wavy Z lines that someone biopsied and there was 2 cells of intestinal metaplasia, I still make them prove that they have reflux. Okay. But if they have a segment longer than 3 centimeters, I'll say you have reflux.
By the way, parenthetically, I want to say, and we'll get to Barrett's in another part of this course, I don't consider Barrett's in and of itself an indication for a Nissen fundoplication. I think medical therapy works, it's effective, and Nissens have enough problems that in most cases that's not an indication in and of itself. I think the reflux and the reflux symptoms are what we were trying to work on here.
Sure. In my mind, and I can ask Ronnie this, in my mind a good candidate for a fundoplication would be a patient who has heartburn and regurgitation. Heartburn completely resolves on PPI, but they're left with bothersome regurgitation that isn't responsive to medical therapy, be it PPIs. We also here, just to give us a plug, we studied this special reflux reducing pillow system at night. So patients who have nocturnal reflux when they lay down at night, there's a new pillow that just came out that locks patients into their left position, their left recumbent and upright, and we showed that that significantly reduced or resolved nocturnal regurgitation and nocturnal heartburn in patients who didn't respond to PPIs. So I consider that part of my medical management of reflux. But if I have a patient who has heartburn well controlled by PPI but has bothersome regurgitation, I usually think that that's a pretty reasonable candidate for fundoplication if they have objective evidence of reflux.
Yeah, the other thing I wanted to mention, which makes me want to do an operation, is patients who have aspiration pneumonia. Regurgitation with aspiration pneumonia is a serious problem, and even if their heartburn is controlled with PPIs, if they're aspirating and they're ending up with pneumonia, then I think we have to tighten up the LAS to prevent them from aspirating. So that's another indication we don't talk about a lot.
I'd like to,
Kevin.
if there's a moment, to go through a few of the questions from our audience. I can alert the crew. So
Good.
The first question from Dr. Jafar is, will a PPI stop the reflux or just stop the acidity? As well, second question is, what about the role of a prokinetic agent? So maybe Ronnie or Scott, do you want to talk about those?
Very good.
I can let Ronnie go.
Ronnie, what do you think? Will the PPI stop the regurgitation or just the burning?
Well, I go back to what Scott says, and I think we need to do a better job talking to our patients. Reflux is acid, but there's a mechanical component of it. And the pills will not change the reflux or the regurgitation part of it. And I agree with Scott, when you find a patient who has reflux and regurgitation and you take care of the acid, it's reasonable to do that. Well, the patient, to do a fundoplication, I think the patients need to understand the same part also. And that's where all this elevation, these new pillows, diet modification comes into play. That we may block the acidity of whatever comes back, but the quantity of what comes back we cannot change, and that's when surgery and these other things come into play, including weight loss. And the patient, explaining that to the patient may be an important role in improving their symptoms and expectations. Patients think that they can take a pill and they can go out and eat 3 pepperoni pizza and nothing's going to happen. And I think they need to understand that. I don't think PPI alone is a solution in patients with a very incompetent LES or a big hiatal hernia. So
let me just ask a more basic science question, because I need some help here. Let's assume that you put the patient on PPIs. PPIs raises the gastric pH. Raising the gastric pH is the stimulus for gastrin, and gastrin actually increases the LAS pressure. So isn't it theoretically possible that a PPI, by raising the GI pH and stimulating gastrin, could increase the LASP?
It's an interesting theory, though.
Doesn't work.
Though I'm not aware of any studies that. I guess a good study would be if a pH impedance test on PPI, if it actually decreased reflux episodes. I'm not aware of that study. It's an interesting theory. There are some doctors, though. There's some esophageal experts who will say that any symptom that isn't responsive to PPI is due to overly sensitive nerves in the esophagus. Some world-renowned experts will say that, and that may be true for many patients. However, there are cases of true bothersome volume regurgitation. Those are the patients in my mind that really respond best to some anti-reflux surgery.
Right. Those are the ones that are most urgent, because they really do end up in the hospital with aspiration pneumonia. All right, do you want to go on with this case?
Sure. So we asked a similar question to what Kevin had offered before, but as a gastroenterologist, I wanted to offer option D. Take your PPI because a surgeon will only make you worse.
Yeah, we could.
In this case, it's open to interpretation. I think that in this case, a Nissen fundoplication would be reasonable in this patient. You mentioned the radiofrequency ablation of the lower esophageal sphincter. Studies have shown it doesn't really reduce reflux up into the esophagus. You mentioned it may burn some of those nerves that are overly sensitive. That may be where some patients get symptom benefit. The LINX procedure is sort of in the infancy, and then PPIs. In my mind, I think this is a good fundoplication candidate. I wanted to ask, and you brought this up, the BMI question. In my own practice, I'm always hesitant to offer a fundoplication to a patient whose BMI is over 30. Maybe Dr. Hayek is telling me that it's not unreasonable to offer a fundoplication to a patient with a BMI of over 30. But in my mind, I think that these patients who are 30 pounds overweight, they really need to work hard at weight loss. That will decrease reflux in those patients.
The frustration I've had with some of these patients, some of whom are aspirators, is that the insurance companies will not pay for gastric bypass on the basis of reflux. They'll only pay for it if the patient's gone through a documented dieting program for obesity. So it is a good treatment for the regurgitation and for the reflux, yet it isn't often compensated if you want to use that as the indication. So it's frustrating.
Sure.
Okay, let's go ahead with that case. More? Is there more to that?
Well, it is somewhat similar. If the hernia was 5 centimeters, that actually takes the magnetic bead augmentation off the table, because I think you can only have a small hiatal hernia 2 centimeters or less for the LINX procedure. So I think in that patient, they surgery may be very reasonable.
So the magnetic bead thing, and this is very new. Nobody really has a long series of these. I want to, I have white hair, and so and Ronnie doesn't have a lot, but he could remember perhaps something called the angel chick prosthesis. And the angel chick prosthesis went around the esophagus just like the LINX does, only it was made of silicone. And years later, we ended up fishing it out of the GI tract. And so we have a little bit of skepticism about the LINX, and we're a little worried about its long-term efficacy and complications. So we have to wait and see how that turns out.
Sure. And I'm not sure I don't know if we offer this here at main campus or
We're
not,
about to, but the point is it would be under some study when we did it.
Sure. Sure. I wanted to ask our surgical colleagues, when you start getting these large hernias, these more paraesophageal large hernias, I wanted to just briefly touch on the role of lengthening the esophagus. As a gastroenterologist, can you talk to me about what it is lengthening the esophagus, how you do that surgically, what patients need that? Do you need anything from us in order to figure out if an esophagus needs to be lengthened?
Oh boy. Okay. Dr. Hayek, you want to get into that?
Yeah, I guess one option would be to wait for Dr. Murthy. Experienced a number of challenging conversations about the quote-unquote short esophagus. Being trained by excellent foregut surgeons, we were able to really mobilize the esophagus even with very large hiatal hernias. Type 4, we are able to mobilize 4 to 6 centimeters of intra-abdominal esophagus. I believe that in recurrent cases, there is potentially a role for esophageal lengthening. I don't usually practice routine esophageal lengthening in the setting of even large hiatal hernias. I do have a case, I'm not sure we'll get to it, but a case of what I believe was a true shortened esophagus, but generally speaking, performing a callus fundoplication, a callus Nissen, is not something I perform, and usually I'm able to get a fair amount of esophageal length just with dissection.
So I would like to add to that, if my former colleague, Dr. Tom Rice, were here, and he's a thoracic surgeon, he would say yes. The school from Griff Pearson in Canada and others would say yes. In any one of those that looks a little short, we would do a lengthening procedure, which is a callus Nissen, and has a greater risk of leak and other problems and mechanical problems afterward, but they would definitely say to do that. Most of the general surgery world would say that in over 90% of these patients, we can bring, as Kevin said, enough esophagus down to do a good wrap without lengthening the esophagus. We think it is effective without having the increased risk of that. So you want to go on to the second case you have? Or? Or you wanted to?
Absolutely. I just wanted to ask one more question. This is the same case. Now I have, instead of having a nice normal peristalsis on the patient's manometry, now this patient has a little bit of a weak manometry. You see here, you know, he has one swallow where there's more of this low pressure in the body of the esophagus. This may be a weaker swallow. And then here, this is what we call a failed swallow, where nothing was transmitted through the esophagus. So in this patient, say 50% of the swallows are fairly normal and then 50% of the swallows are failed. Does that change your surgical approach? Do you change the type of wrap or the type of surgery?
So that's a
you do?
great question, Scott, and let me address that a little bit.
And maybe we'll ask everyone here, because
Yeah.
I have a nice poll question, and I put a whole bunch of different surgeries on there.
So let me just address that a little bit as the audience decides what they want to do. Here you have demonstrated a patient with some failed swallows, with some weak peristalsis, but with a low LES pressure.
Yep.
And the information that I want off of manometry is, number one, is the LES pressure low? Does the LES relax with swallowing? Because the way we started doing a lot of achalasia patients is we started doing manometry in patients with heartburn and found out some of them had achalasia, not reflux. So, okay, this patient has a low LES pressure, but he also has weak peristalsis. And for years, we realized that if you made a tight sphincter at the bottom with a Nissen wrap and you had weak upper esophageal peristalsis, you wouldn't be able to overcome the tight wrap and they would get pseudoachalasia above it. So we started doing wraps that were less tight. As you mentioned, the toupee wrap, which is a 180 or a 270 degree wrap, like an open collar on the shirt, rather than a turtleneck like the Nissen. And that was the dogma. There was then a paper by Lee Swanstrom and others, and John Hunter, which looked at this and actually showed that part of the reason for the weak peristalsis and failed swallows in many of these patients with bad reflux was the reflux itself. It had injured the esophagus. And if you did a loose Nissen wrap, it actually caused a return of better peristalsis. And so they recommended, instead of a toupee, a floppy Nissen, which would allow the recovery of some motility in the esophagus. And this could still be debated. I will tell you that when I have a patient who has scleroderma or one of those connective tissue diseases, I will often do a toupee wrap, which is that partial wrap, because it allows anti-reflux without obstruction. So what do we have there on our poll? 75% of them went for the toupee. I think that's a reasonable approach.
I think it's certainly dependent on the surgeon and obviously the gastroenterologist and surgeon talking together. But I think either a floppy Nissen or a toupee is very reasonable in this patient. So Dr. Ponsky had a nice lead into this. Now, what if the patient's manometry is this? I'll tell you, this is a dead esophagus. So
let's have the slides back here again. If we can get the slides back on for this case. Why don't you just, okay, so go ahead and tell us what they show, Scotty.
So this manometry here shows that the upper esophageal sphincter looks normal, and you see some peristaltic activity at the top of the esophagus. So the striated muscle of the esophagus is working okay. Then you get into the bottom of the esophagus, the distal esophagus, and this is here. This is all not squeezing. This is dead muscle right here. So again, you have an upper esophageal sphincter working normally. You have some peristaltic activity in the section that has striated muscle. Down here where the esophagus is made up of smooth muscle, there is nothing going on. And this example, this patient has 10 out of 10 swallows, nothing going on whatsoever. This looks like scleroderma or some connective tissue process, mixed connective tissue disease. So Dr. Ponsky had a nice lead-in. So what surgery would you offer if you had a patient who has no peristaltic activity in the esophagus? I think that it's reasonable to offer a toupee. In patients, if if they are a little obese, there's some data to suggest that these patients actually don't do that poorly with a bypass, with a parietal separation procedure that Dr. L. Hayek mentioned, a bypass. Their BMI will go down by about 2 or 3 points. So if their BMI is 33, 34, and you can get the procedure covered, there is some data that a bypass isn't unreasonable in a patient whose esophagus isn't working.
So we've actually learned something from all this bariatric and metabolic surgery. This operation of gastric bypass, Roux-en-Y, started out as an operation which had a restrictive and a malabsorptive component that was used for obesity. And then we found out it took care of type 2 diabetes, and we did a trial which we showed in patients who had diabetes and who were not obese, that the operation did just what you said. They may have lost a little bit of weight, not much, and it cured their diabetes. Now we're looking at the same thing in a specific case of esophageal reflux where you can't do a wrap. These patients who you mentioned with scleroderma often have terrible esophagitis, even strictures, but you dare not put a big wrap in there because they can't overcome the resistance to it. So this may be a perfect case to do a Roux-en-Y, and maybe you modify the length of your Roux limb so you don't get much weight loss. Kevin, do you want to comment on that at all?
Sure. I think actually I chose Take Your PPI on this one, which is about a third of the patient, a third of the poll. There's no, these are cases that unfortunately surgically it's very challenging, even with a gastric bypass, because you're still going to have a lot of the esophageal dysmotility problem. So these are patients I get second, third, fourth opinions prior to operating on them. Even with gastric bypass, these patients become somewhat crippled from the disease, and there's very little aside from esophagectomy in some cases for these patients, which I think is quite drastic.
Okay. It's a tough case all around.
It's tough. There isn't a great answer to this one. I think if you're pressured, absolutely pressured, like Dr. Ponsky said, if you think their reflux is contributing to aspiration or a pulmonary disorder, maybe taking the approach, very drastic approach. But otherwise, I think Dr. L. Hayek brings up a great point. Dr. L. Hayek, while we're on the subject of weight loss surgeries, I see a lot of patients getting sleeve gastrectomies for different, for weight loss. What do sleeve gastrectomies do to GERD? Does that help GERD? Does that make GERD worse?
There is, the jury is out on sleeve gastrectomy for GERD. We have looked at GERD in patients with post-sleeve gastrectomy. We've looked at GERD from all comers, and in some series, about 30% of patients develop GERD. However, in series with patients with high body mass index who undergoes what we call a tailored sleeve for hiatal hernia, those patients have resolution of symptoms. The problem is long-term, the durability of a sleeve gastrectomy for reflux is unclear. When we followed some of those patients long-term, we noticed that their GERD came back in a rate higher than 30%. And the problem with performing a sleeve gastrectomy is you have somewhat of a burned bridge because you take out the fundus. So if those patients, the only recourse for a patient who has a sleeve gastrectomy is conversion to a Roux-en-Y gastric bypass. So it's a controversial topic, and depending on the study, you can see that it can cause GERD, and in some cases we've seen some improvement with GERD. So it's a tough question.
Okay, you want to go on to your...
I can go on, and I hit on all of this already, but we'll talk. This is a similar case, and just drive home the point. I think in clinical practice for gastroenterologists and surgeons, you're probably more likely to see a patient like this than the first patient I showed you who was a good surgical candidate in my mind. We have a 45-year-old female who she says she has constant sensation of burning in her throat and chest. It's not responsive to PPI once a day. She was put on dexlansoprazole twice a day, and she thinks maybe if you pressure her, 25% improvement to the constant burning in her chest and throat. She says she doesn't have any medical history, but she takes alprazolam. So when you pressure her, she says, oh yeah, I think I have, or they're giving that to me for anxiety. And she had a cholecystectomy 5 years ago. When you ask her if she had stones, she said she didn't have stones, but she had an abnormal HIDA scan, and that's why they took out the gallbladder. So she gets a scope, and you can see here, this is a nice regular Z-line. This could be on the cover of Z-line magazine. You have no erosive disease. She has a 1 centimeter hiatal hernia, though it goes away during the endoscopy. It sort of comes and goes. So overall, a pretty normal EGD. So I wanted to ask the group, what's the next best step in her management? Do you do a pH and impedance test on dexlansoprazole twice a day? Do you do a wireless pH-only test on dexlansoprazole once a day? Do you do a wireless pH test off of medications? Or do you send her for that magnetic bead surgery because she has GERD and she has a small hiatal hernia, so she doesn't have a contraindication?
Well, this is a question that I always ask because I never know when ever to do a pH test on medication. So I always do my pH tests off of medication. I'm simplistic. Explain to me when I should do one on medication.
So in my mind, if you're doing a pH-only test, so if you're doing a wireless pH probe, because that only gives you pH, or if you're doing a nasal pH-only catheter, I have rarely, I can't remember a time that I did one of those on medicines. I think those should only be done off of medicines. If you're doing a pH or impedance test, you can do it on or off of medicines. The one issue is that they're actually quite cumbersome. The computer-generated reports don't do a good job, so you yourself have to go through this long study and look at every single minute of the time. So if you're willing to do that, I think it's reasonable to do the pH and impedance on medications. In my own practice, I do most of my pH tests off of medications because I like to, one, figure out, does the patient have objective evidence of reflux? Do they have abnormal gastric contents coming up into the esophagus? A negative pH test off of medicines proves they don't have reflux as the cause of their symptoms to me. And I guess I could ask Dr. Pimentel what his own practice is on pH impedance tests on or off medicines.
I agree completely. What you want to see in a case like this is to prove that they do not have acid reflux, and if they don't, you can manage them with SSRIs or TCAs. Sometimes I tend to do, rather than a Bravo, I tend to do an impedance including, so you get the two answers at the same time. There's no acid and there's no non-acid reflux coming in, and you also look at the correlation of symptoms and changes in either reflux, acid, or non-acid. You're looking for a negative acid. That's why most of the time I'll do it off medication.
So I want to just stop you guys because there are some simple people out there like me that may not understand exactly what impedance shows you.
So impedance is an electrical measurement, how well the electrical current transmits through. So air has a very high impedance and liquid has a different impedance. So we're actually looking for liquid coming up into the esophagus, and that changes the electrical, the way that the electrical current is transmitted through. So it's a measure of liquid coming up in. The pH impedance catheter has both one pH port and then all these impedance probes, and when you see the impedance climbing up the esophagus, you know that there's a reflux coming up. Regurgitation, yeah, coming up.
All right, so a positive impedance test, even with a negative pH, may be an indication for surgery.
Well, it again depends on
Can't
patient
get you to
selection.
operate, my God, okay.
It depends on patient selection. In someone who has overlapping functional diseases, like this patient may, I'd be hard-pressed to offer surgery. but I wanted to show you her results. So we did a pH test off of PPI. And this is, again, I'm at a tertiary care center, so I get the patients who don't respond to PPI, so quite a few of them don't have reflux as the cause of their symptoms. But this patient's pH off medicines, she had a total time with the pH less than 4 of 2%. That's normal. So if you take all of us, we all have some reflux throughout the day. We all have about less than an hour's worth of reflux, I would consider normal. So normal is less than 5.5%.
Used to be less than 4%, didn't it?
Well, no, they change depending on which pH test you actually get done.
Okay, all right.
So she had 2% of her time was pH less than 4, so that's a normal amount of reflux. And she pushed the button 19 times, and only 2 of those were associated with reflux disease. So in the 2 things that I mentioned before, functional heartburn and hypersensitive esophagus, this patient actually has, oh, well, here you go. Now we can see if people are learning. How would you classify this patient?
While we're getting that, I want to introduce Dr. John Rodriguez, who's one of our surgical foregut surgeons who just was able to join us. And John, we're going to get to your cases in a little bit, so hang on there. Personally, I would say C in this one. What did you?
So this patient actually has functional heartburn. So again, when she hit the button 19 times, only 2 of them, 10%, were associated with reflux. So this is what we call functional heartburn. So there's no correlation whatsoever between acid and what she's feeling. Hypersensitive esophagus would be if she hit the button 19 times and 18 of them were associated with reflux, over 50% of them were associated with reflux. That's what we call hypersensitive esophagus. Now, the fortunate thing is they're both kind of treated similarly. You treat them with pain modulators. So I want to ask how people would treat this patient. I sort of ruined the poll.
So I don't know how those drugs work.
So amitriptyline and citalopram both modulate serotonin. And actually they've shown that serotonin, the majority of serotonin in the body is made in the gut. And obviously that has a huge role in anxiety and depression. It also has a role in pain transmission of the visceral nerves in the esophagus and throughout the intestinal tract. So there is data for low doses of tricyclics. I personally use amitriptyline, dose of 10 milligrams at night. They used to use doses up to 100 or 300 milligrams for depression, so that's a very low dose. Or citalopram, a selective serotonin reuptake inhibitor, 20 milligrams a day. Both of these medicines have shown to decrease functional GI problems. So either amitriptyline or citalopram in this patient would be reasonable. She has overlapping anxiety. Citalopram helps a little bit more with anxiety. So if anxiety is a big component of her symptoms, you may get a little bit more benefit from the SSRI. In my own practice, if pain is more of a problem, the amitriptyline at night helps a little bit more with pain. So my patients who have anxiety predominant symptoms, they get an SSRI. If it's pain predominant, tricyclic antidepressant. And I don't know if Dr. Pimentel has any other thoughts.
Ronnie, you still there?
Yeah.
So what do you think?
I agree. Sometimes I use trazodone for people with upper GI symptoms. And
that's another great medicine.
Remeron for diarrhea-like IBS.
So the type of drug is important.
TCAs in elderly people because of the profile of arrhythmias and things like that.
Okay.
And more SSRIs in older people and younger patients, more TCIs.
Okay, folks, I want to be able, so we're having a little problem with the internet right now, and this is a perfect time to take our break. We're going to take a 15-minute break right now. Everybody stretch and relax. We're going to come back with the next section, which is on motility, in 15 minutes. So I want to thank the participants, Scott and Ronnie, and I'll see some of you again. So we'll be back in 15 minutes. Thank you.